the non-operative management of hand fractures. I've been banging on about this for many a long year, as some of you will know, and it seems that at the moment this is very pertinent. So I have an attentive audience for once. What I'm going to discuss is non-operative treatment in general, and then I'm going to talk about specific injuries in the hand, and I've sort of grouped them loosely into those where there's some good evidence and those where the evidence isn't quite so good and it's more opinion, and some of it's a bit more controversial for you to think about. So this is where there's good evidence, and this is a rather shorter list of some evidence. So at least you'll know when we get to this bit, the end is in sight. So non-operative treatment, well, Nicholas Barton was talking about this back in 1984. There's nothing terribly novel about this. And he was a very bright hand surgeon with a lot of foresight. So the principles of non-operative treatment, and really this should be the principles of all fracture management, in my opinion, are as follows. We should treat fractures non-operatively where the non-operative treatment is so good that surgery couldn't improve the outcome. So I've done 1 or 2 studies on these, and with some injuries, the hand does so well, you really couldn't improve it with modern surgical techniques. So in my opinion, don't try. Or there is some published evidence, and it shows that surgery is really no better than non-operative treatment and often has complications. And I think particularly in a Montgomery age in the UK, where we are better, I hope, at advising our patients, if we can tell them that really non-operative treatment can't be improved on with surgery, it's very difficult to consent them to operate. But do remember that although this talk may be recorded, it's not set in aspic, and in future so there may be new surgical techniques and things may change, and we may be able to do better than we can do now. So I don't think what I'm saying now is necessarily going to be true in 20 years for all of it. So before I talk about non-operative treatment, I want to acknowledge that some fractures need surgery. You know, I'm not sitting here saying nothing can be treated with an operation and you've got to do everything non-operative. That would be silly. So we can therefore exclude in this talk those that we're clear need surgery. And I would put this list in: open injuries, displaced intra-articular fractures. I put a question mark there because I think we overtreat those, and we'll do a little bit of, I'll talk a bit about that. Irreducible fractures, multiple injuries, complex things. So even I would treat this operatively, you'll be pleased to know. So what is non-operative treatment? And I think that often it's talked about very loosely and non-specifically, and there's an art to it, an art to getting your patients to do well. It's certainly not no treatment. It's not abandoning the patients, though often it's very little treatment, and that's got to be appropriate in the current time for many injuries. Typically, I think it involves careful follow-up. That may be weekly for 3 to 4 weeks. And I know a lot of you will be thinking, well, hang on, we can't do that now. We don't want to bring our patients in. But I think a lot of that we can do over the phone. And maybe in this current era, we're going to have to compromise a bit. I think we need to be better at explaining to our patients what to expect, telling them what their hand will be like at week 2 or 3, what it'll be like at week 6, and so on. They're not going to remember all of it, but they'll remember some. And I think it'll be easier for them to follow the treatment and do well. You may use various splint straps or plasters. I suspect we mostly overuse those and we don't need them. You may need specific therapy, and you may need to re-X-ray patients. And I'm just going to put a quick word in about X-rays. I want to talk about the role briefly as a therapeutic re-X-ray. I think patients often expect to get X-rays when they come, and it doesn't mean we should necessarily do it, but they're often reassured by it. It gives them a chance to go off and mobilize, so you can see them, send them for an X-ray, they can get their hand going, and when you come back and examine them, then they might probably a little bit more cooperative. Maybe they wash their hands and so on. And it may give you a chance just to reflect on an injury. You weren't quite sure, you send them away, you reflect on it. So sometimes there's a role for that. And in all of this, I am conscious that you will want a compliant patient. So I'm lucky where I work in Bath that patients largely will do what I tell them. So when I take them out of a plaster and tell them to make a fist and they say, I can't possibly do that, I say, oh, you'll be all right, go there, get the tap, turn on the hot water, and then you'll make a fist. And mostly they do it. But I know that not everywhere are they so compliant, and it may be that some of those patients are not so suited to non-operative treatment. I would also argue that possibly they're even more suited because they're less suited to surgery. So now to come to the meat of the talk, before you thought I was going to philosophize all evening, and I'm going to talk through a range of fractures, starting the less controversial ones where I suspect you'll largely agree, and then we'll move on to some areas where you may not agree so much. So with metacarpal fractures, I tend to break them up simplistically into neck, transverse, and spiral or oblique fractures. And we're going to start with the neck fractures. So you'll have seen lots of these injuries, the fracture here, mildly or even moderately angulated metacarpal neck. And often they come to me in plaster and I get these people going. I tell them to go to the cubicle, get the tap on and start making a fist. And this is the sort of thing. You can see these patients come out of their buddy strapping. They're a week down the line in clinic. They're a bit bruised and swollen, and they can pretty much make a fist already. If that's what they can do at 1 week, then you're not going to improve them by an operation. So don't. And there's some evidence for that. A number of small prospective studies and one largish retrospective one. And they pretty much say the same thing, which is that the outcome's the same whether you operate or not, but surgery has more complications. So currently there really isn't a role for surgery in the vast majority of patients. And really that's what I'm talking about, the vast majority of patients, because you may have some exceptional patient. There may be a patient who needs some perfect alignment of their fingers for playing the piano or whatever else it is. And there may be rarely an indication. But in the vast, vast majority, there's no need to operate on these injuries. And I suspect most of you don't. So transverse metacarpal shaft fractures. These are common. You can see here on this X-ray, the break there. Not so easily, we've drawn a line in on the original X-rays, angulated about 25 degrees. And I just put these in plaster and give them a push. And when I say I do that, we've trained our plaster technicians. They enjoy doing it. We get the X-ray afterwards. They're very satisfied. And in my experience, they do very well. Now, whether they need a plaster or a little splint or some other variant, that's entirely up to local practice. And this is the sort of plaster they're in. They've got good ability to move their hand. They can function well. And we'd immobilize them for about 4 weeks till the fracture's stable. And this has been written about before. So Barton in 1984 and Westbrook and now others from the same unit. And again, they showed similar outcomes with non-operative, but more complications with surgery. But this injury gives me a chance to illustrate an important point, and I will do that in a minute. And that's here. So this is a transverse fracture which is off-ended. And sometimes you can push these back, but in my experience, often they won't come back and they give a somewhat unsatisfactory outcome. So there will be occasions where you do need to operate on these. And I think it's important to recognize this. And I think this is a very big factor in how we manage our patients. And it's this subset bias. So we get biased by a small subset of patients. Maybe you've listened to a talk and someone told you they never need surgery. So you put them in plaster and someone does badly and you think, oh, well, that doesn't work. I'm now going to treat them all surgically. And I think it's important to understand there will be some subsets. There will be occasional patients for who you specifically need to do an operation. And in this case, that's one of them. So now I'm going to talk about the spiral or long oblique metacarpal fracture, which is one of my favorites. So here we see an example of it, and this injury applies whether it's 1 or 2 or even 3 metacarpals, you can do well. And what you notice here, and this is crucial to this management, is this is shortened down, here perhaps 1 millimeter or 2, sometimes a bit more, and it's these intermetacarpal ligaments that are resisting further shortening. So this is where you now get a demonstration, you'll be pleased to know. So this is my simulated metacarpal shaft. Here's my metacarpal head, and here my intermetacarpal ligaments. And normally I'm just sitting here, no problems, relaxed, and these can tighten a bit if necessary. But when I break, I shorten, but these tighten up. So these limit the amount of shortening that will happen. And we did an anatomical study on cadaver and humans many years ago, where we were able to show that the intermetacarpal ligament is the key structure limiting the shortening. And other authors have looked at shortening, and really shortening of 2 to 5 millimeters doesn't make any difference. So this is an example, that last fracture. This is the lady. She came to clinic at about 1 week, and we got her to make a fist, and you can see the right ring finger knuckle is slightly shortened, but already she's making a very good fist at 1 week. You can't do better than that surgically, so don't try. And these patients do very well. Now, they don't all make quite as good a fist that early, but most of them do. And there's some work on this. Al-Katan wrote about surgical techniques. We looked at a number of patients and found that pretty much everyone did really well with early mobilization. So I think there's almost no indication for surgery in these fractures. And all of ours had some degree of malrotation on presentation. And that corrects as they shorten with those intermetacarpal ligaments tightening up. So now I'm going to talk about avulsion fractures. And again, this is an area of particular interest of mine, because I think it's staggering the amount of different opinion and different publications that there are out in there. And I'm going to talk about this in relation to the fingers at the thumb, PIP joints, and also at the thumb. So here, this is the sort of typical bony avulsion injury we see in the thumb. Now, with these, I'm not talking about the soft tissue injury, the common ligament injury often with a stena lesion, but I'm talking about when there's a bony fragment on X-ray. And you see here, the radiocollateral ligament is pulled off. Here, another one, bigger fragment, and here, the ulnar collateral ligament. Now, the key with all of these is to understanding the anatomy, and I'll go back through them. The ligament is attached here. On the radial side, there's no hood for it to slip under. So it's going to sit there and reattach. And there's quite a wide base of attachment. And although this looks widely displaced, that doesn't really matter. Here it's not so displaced, and that will reattach. And here it's displaced. But again, here on that side, you're not going to get a stena lesion. Now, I know some of you will note that 1 or 2 cases have been reported exceptionally in the literature of bony avulsion and a stena lesion, but those are vanishingly rare. And again, that's a subset that we don't want to get too biased by. So if we look at the thumb, radial and ulnar collateral ligaments, there are multiple papers reporting good to excellent results. And one of the reasons they're concerned about that is because of non-union. But the non-union doesn't seem to matter. And Serene and Goodwin reported on this in 2003. They followed up patients over a long period who had ulnar collateral ligament injuries of the thumb. They showed that 60% of them had non-union, but it didn't matter because the outcomes were very good. and they gave similar outcomes to operative treatment, but with fewer complications. So like a lot of this stuff, if you do an operation for an injury that doesn't really need surgery, they'll probably do absolutely fine. And you probably be a bit wealthier if you do it privately, but it's unnecessary treatment, and I would discourage it. In terms of what treatment I do, I tend to put these in plaster for a few weeks and then maybe get them to a splint, rather like the one Mike Hayton has proposed. Whether even that's necessary if they're pretty stable, I suspect is arguable. Here, finger avulsion injuries at the MP joint. Now, this is a very interesting one because two of the particular papers say completely opposing things. I was involved in writing in one of them. So David Schuring wrote the other, a very good and very skilled surgeon. And he wrote that these injuries always needed surgery because of the risk of non-union and subsequent problems. And I'm sure he's right that a lot of them will have non-union, but as with so many of these injuries in the hand, a bit like the avulsion of the tip of the ulnar styloid, it doesn't really matter. So we did a study looking at patients that we treated non-operatively, and we found that they all did fine. One of them needed a steroid injection at about the 6 months mark, but otherwise they did really well. So this is an injury where I think the evidence shows, again, you don't need to operate. And what we reported at the time was neighbor strapping for 4 to 6 weeks and then getting going. Now I would tend to only neighbor strap for a couple of weeks. I suspect we over-treated them. Right, so now we are going to stop the screen again, but this is for a different reason, because I want you to all stand up with me and stretch, wake up, recharge your glasses, okay? Go and grab a coffee. And even if you're listening on this on repeat, this is a good time to have a break because you're already 20 minutes in and everyone's losing interest. It also gives me the opportunity to show that even on lockdown, I'm wearing red trousers. I knew you'd be disappointed if you hadn't heard that. Thank you very much, Sophie, for the thumbs up. Much appreciated. Right, so if you've all had your stretch and you wake up and you come back to life, then you can hear me droning on again for a bit longer, provided I put the right share up. Jolly good. So now I'm going to move on to a recent interest in mine in intra-articular injuries and the role particularly of gliding. And I will, in the course of this talk, I'll try and persuade you that this is one of the great nirvana concepts for these joints. Of course, I may fail to persuade you, I may not be right, but this is where I'm going to try and persuade you. So bony mallet injuries are common, and a lot of you will have been taught, and what I was taught in training was that we need to operate if the fracture fragment of the base, the dorsal base of the distal phalanx is more than 1/3. So that's been written about widely, although more recently, authors have been talking higher numbers, somewhere around 48% in a study published in 2017. So it's this sort of injury here, quite a big fragment, and you worry, the concern is this main distal fracture fragment going to sublux volarly off here? Because if it does, you may get that problem, which is a bit of a disaster. This is a very nice medical student treated elsewhere who I saw subsequently, and there's really very little you can do about that. Now, most of the time that isn't a big problem, but we want to avoid it. And so what I propose, and I published on this a few years ago, is an extension stress. And I'll explain what that is. So what you do is you apply an extension stress, and you see here, we wouldn't normally x-ray it straight like this, but that happened. And then the extension stress tipping the distal phalanx back. So if I show you here, you just teach the patient to push back, and they can take an x-ray like that, or you could do it with a pencil or something else. Okay, so it's quite straightforward. I see the patients in clinic at 1 week or so, and I send them round for a lateral extension stress X-ray. There's not going to be agony. They're normally reasonably comfortable enough to do it. And when we did this, we found that we thought there'd probably be 2 types of patterns, and which are pivoting and gliding. And gliding is the important one. There's a third one, which I think is probably a subset of pivoting, and I'm not quite clear, but it's less common. So this is the first one, and you can see here that this has clearly pivoted at that point. So there's opening up at the front, and it's tipping back, right? And I hope you can all see that. Now, what that shows is that there's been damage to the front structures, because this is not an avulsion injury. This is a dorsal impaction fracture, but that's a subject for another talk. And in this one, done in a slightly different manner, but there's still an extension stress, you can see, even though this fragment is over 50%, the joint is gliding. You can see the distal phalanx is still staying congruent to the end of the middle phalanx. And then in this one here, again, with quite a big fragment, we tipped it up, and it's not so easy to see, but there's a bit of gliding and a bit of pivoting, and that's what we call tilting. And that's probably somewhere in between, but we'd be more worried that it was a pivot than a glide. And so we did this study, and we found that when they pivoted, they had a high risk of subluxation. Now, it's not inevitable that they will sublux, but if they pivot, you need to keep an eye. Now, there are some authors who will suggest that even if they sublux, it doesn't really matter, as most people do fine. And that, to a certain extent, they're true. And I think if they sublux 1 or 2 millimeters, it doesn't matter. But sometimes they sublux more. And that is, for me, an indication just to stabilize the distal phalanx, put a wire across to hold the joint. And that's indicated by pivoting. If they glide, however big the dorsal fragment is, and one of them was 72% of the width of the base of the distal phalanx, they all remain stable. And almost certainly these have not sustained such a big injury to the volus structures, particularly the collateral ligament attachment. And if they tilt, it's a bit unclear, so we would watch those. So how does that affect treatment? Well, what this means is you can predict to an extent what the outcome will be, and therefore guide your management of these patients better. And remember, that's what we do an awful lot of our practice. We are crystal ball gazers. We're trying to predict what will happen if we do something or do nothing, and that's why we decide. So if you get them to pivot, if you do a lateral extension X-ray and they pivot, then I splint them, and logically you should splint them in slight flexion, because if you splint them in a stack splint in slight extension, you're just accentuating the original injury, which is a hyperextension injury. And I watch them up normally for a good 3 weeks, because they may slip. And if they do, then I'll have a discussion about wiring. If they glide, I'll just put them in a splint, similar splint, get them, and then tell them to wear the splint full time for 4 weeks and gradually mobilize from there. And I wouldn't typically see them again, because they do fine. And if they tilt, which is very infrequently, then I'll watch them as for pivoting. So again, we're able to stratify this injury down a bit further to work out which ones we may or may not need to operate on. So once again, it's that subset bias where people, I think, have looked sometimes at the wrong thing, i.e. just for the size of the bony fragment. And yes, if it's small enough, you don't need to worry. But if it's bigger, you need to somehow assess the soft tissues. And this seems to be a way of doing that. So Bennett's fractures. This is really a fracture subluxation, and important to recognize the subluxation, because that's really what we're treating. And if you read the textbooks, it's widely reported that surgery is needed, and it's widely reported that non-operative treatment gives high rates of malunion and osteoarthritis. And like many of these things, I think these dogmas go along and they don't get challenged, and you need to challenge them. So we're talking about this injury with this bony fragment down here. And so I did this systematic review with Gray Edwards, And when I say I did it, what I mean is he did most of the work and I put my name on the end of the paper, and he'd worked jolly hard. So we looked at the usual systematic review, lots of studies coming out until we could find enough relevant ones. They were all retrospective, and the treatment options varied greatly from a range of operative and non-operative treatments. And some of the non-operative treatments were simply, well, wrap them in a bandage and send them off. And it's interesting to look at the data, given that, you know, we have been told so much how we should operate always on these. And so we look at pain at follow-up in the long term, 23% who'd been treated operatively, 33% treated non-operatively, but they had been followed up longer and they may have had a bit more OA. So this was significant. So it had a bit less pain with surgery. But if you look at return to work, pretty much the same. Almost all of them returned successfully to work. And if we looked at osteoarthritis, exactly the same numbers. Now, of course, you can argue about the quality of assessment of that at such a difficult joint, but there's no substantial difference. And if we looked at complications, well, as you'd expect, they were much greater for operating than for not operating. So for this injury, really, there is no good evidence you need to operate. Now, I think most of us would feel we don't want to leave the joint subluxed. We want an adequate reduction. So I'm aiming, when I'm treating these, to get a reduction within 1 or at most 2 millimeters. And most of the time you can do that in plaster. So we look here about this fracture and we've reduced it. Not perfect, but it's pretty good. You may or may not notice this is a modified Bennett's plaster, or what we call that, because it's easy to get hyperextension at the thumb MP joint, and then that tends to tip the metacarpal into flexion, which subluxes it out. So what we do is this is a 2-part plaster where we put a first bit of plaster on, flexing the thumb MP joint as much as comfortably possible, sometimes 50 or 60 degrees. And then we put the standard Bennett's plaster on. You can see that's why it's sitting off here. It's pressed there, it's pressed there. And normally you can get enough fixation to hold that without this hyperextending. And that seems to help secure these. Now, again, I'm not saying none of them need surgery. I can't get all of them adequately reduced in plaster, but I reckon I can get about 2/3 adequately reduced, avoiding surgery for quite a lot of them. And you need to watch them. You need to make sure that they don't then sublux again over the next 2 weeks or so. Now a little bit of esoteria just to keep you going. So hook of Hamate fracture. This is a series, a retrospective series reporting on this. And I suspect most of you don't go around either seeing lots of these or operating them. But it's nice to know that really the evidence supports us in not operating. This was a series from the Mayo Clinic, a retrospective series, and they showed that operative cases, mostly which were fixing, they put a screw down here, which is an elegant looking operation, but unnecessary, did as well as without surgery. And I think it's important to think of this in terms of the concept of bailout. I think bailout's a very important concept. Doesn't apply a lot of the time in fracture management. It's often more in elective, non-urgent cases. But the idea here is, what are your treatment options? Well, your treatment options are, if you're going to operate, you're going to go in and fix that now. But if you're going to do it non-operatively, do you have a bailout? Well, you do, because if they get a painful non-union, you go in and remove the hook. And they do just as well as if you do an early operation. So why wouldn't you wait? There's no reason not to wait, again, unless there's some exceptional reason, like maybe some athlete who needs to get back to sport very quickly. And then nightstick fractures. I thought I'd mention this, although not strictly in the hand. Again, an area of interest of mine. And this looks like an injury where you'd think, I mean, we all sort of instinctively dislike the look of this. It's displaced. We like our bones to look as God made them, not as man recreated them. And we worry about non-union. So we think we should operate. So we did this systematic review. Again, Kai did most of the work and I put my name on the end of the paper. And we looked at a number of papers of studies looking at it. And then this has recently been confirmed in a small randomized control study, this not being a common injury. And essentially, the patients treated non-operatively did as well or better than the patients treated operatively. And in fact, the patients treated with early mobilization, just with a bit of support with a bandage, did better than those treated with plaster. So again, this is one of those injuries where we should let nature do her bit and we shouldn't interfere. And the vast majority will do fine. Now, one or two still will need surgery and the patients need to be advised about that. But in the vast majority, you don't need to operate. So now I'm going to come to a few injuries where the evidence is less good. And if you remember, I told you that list was much shorter. So the end is in sight for those of you desperately hanging on for your next glass of wine. Cheers. So there's some evidence, but not a lot. So I don't want to pretend that this is a done and dusted set of answers, but I'm hoping you'll think, and I'm hoping I might stimulate one or two of you to collect some cases with me for one of these particularly. So phalangeal fractures, typically long oblique, spiral, and transverse. And I think these can all be treated non-operatively. So we see this injury, a long oblique fracture. People worry about the shortening, but it's only a few millimeters. That doesn't seem to give functional problems. And I was fortunate to see this lady in clinic about 8 years after I'd originally treated her non-operatively. And as you can see, she's done very nicely. Now, with patients with spiral fractures, I tend to strap them down. What I'll do is, if you look here, if they've spiraled, say, into pronation, I'll strap them across with elastoplast, assuming they're not allergic. I'll show them how to do it, and I get them to take the strapping off every day or every other day, gently mobilize the finger, get it going, strap it down again. Not too much, but enough to control the malrotation. And I see them weekly for a few weeks and then get them going. And it's all a bit awkward, but they do very nicely. We correct the malrotation. I've only got a small series as yet, but I've been pleased with that. Now, it won't suit everyone, but it does mean that I think that for a lot of these fractures, you don't need to operate. And I was pleased to see this paper just come out in the Journal of Hand Surgery European from an Australian group where they pretty much they didn't treat the spiral fractures, i.e. the rotated ones, but those with some angulation, and they pretty much got them going, didn't do a great deal. And though some of them healed with angulation, in the main, they got good results. So I think that particularly now where we're not going to be wanting to do a lot of drilling, we're not going to want to bring our patients back to surgery, to a clinic, you may want to have a read of this paper and think how that might further change your management in the few months ahead and maybe long term. Pilon fractures of the MP joint. I don't see many of these, but I'd like to follow this up further. This might be a good idea for the RSTN or another group of trainees or others to just follow the natural history of this injury, which I don't think's been written about. So we're talking about this sort of fracture here. We often see them a bit more displaced, but you've got to remember that the MP joint is a very forgiving joint. It can tolerate quite a lot of malalignment because it's a shallow ball and socket joint with quite a lot of give. And remember that the concave side of a joint seems to tolerate malalignment better than the convex. Now, I've been preaching this for 20 years and I keep wanting to somehow try to be able to prove it, and I'm incapable of doing so. So if someone knows how, I'd be very grateful. But I do think it's true. So we see that, you know, badly smashed up distal radiuses, the concave side do pretty well, but if you get scapholinea instability or a scaphoid non-union or malunion, you can do badly. So for these injuries, these pilon fractures, I tend to treat them with some gentle mobilization, depending on their symptoms, and get going. I tend to hold the view, and again, this is unproven, that the patient's got a pretty good idea of how bad their injury is. So if they can gently get them going and they're not too sore, then it's probably stable enough and going to do reasonably well. If they're extremely reluctant to move it, then that's always a slightly worrying sign to me. Now, maybe they're just a bit anxious, but I think it's quite a good indicator. Obviously, you've got to try to take out the mad, often young male who thinks they can charge away with these injuries straight off. Now to PIP joint injuries, where I've been developing my ideas on gliding. I'm talking here about concave base of the middle phalanx injuries. I'm not talking about the unicondylar or bicondylar injuries, which David Shearing written about very nicely, and where they're displaced needs surgery. But I think, again, this is a concave injury, so it's pretty tolerant of some malunion. And I would also ask the question is, does the sagittal broadening that people worry about really matter? And I don't think it does. So I'll show you a case. This is one where this injury you can see on the lateral is well smashed up in there, and an injury extending up here. And we put on this dynamic external fixator, and I devised this, and the idea was to get the joint to mobilize. What I think we were doing was getting it to glide. I just didn't realize that at the time. And you can see here, the base of that joint is widened, but this patient's got good extension and managed to get good flexion. So I think the broadening doesn't matter. So if we don't really worry too much about the anatomy, we're worrying about the function. And this is where we come again with gliding and pivoting. Now we know this is a joint that can do badly, and that is a bad joint, which is going to be pretty symptomatic most of the time. And we look here, and this is one we would worry about. So there's been a pilon fracture. You can see here, this fragment's pushed up. There's a split up here. This fragment is no longer at the joint. It's been put up, and these are widened. But this was the patient in clinic, even after only 10 days, good extension, good flexion, they're going to do well. So I'm assessing their clinical picture early on, and certainly those who start to flex well, often by about 50 or 60 degrees, they'll do well in the main. I think they don't need surgery. But what I specifically do now are lateral flexion x-rays. So with the DIP joint, I was doing a hyperextension lateral, but for the PIP joint, I'm doing a lateral flexion x-ray. So I teach the patient and send them round. And you can see here, and fracture subluxation, we've got the lateral flexion injury, and you can see they're pivoting here about that point with opening up. In my view, these will do badly if left, and I think they need surgery. Then we look at an injury like this, and you think, well, this is going to do badly. It's subluxed, it's dished in, a good 50%. There's a V sign. So I send them round for the lateral flexion x-ray because he had pretty good flexion, and that's what he could achieve. And at 6 months, at 6 weeks, this is what he had. Not a great looking joint, but he had nearly full extension, flexion to over 100 degrees, very good DIP flexion. And I don't believe you can achieve that surgically. Now, will that give long-term problems? I don't think it will. I think these joints are pretty tolerant, but I hope I'm right, and we'll need to follow that up long-term. Maybe I'm pushing that too far. So when you take an injury like this, that's going to pivot, but I want it to glide. So I am attempting to restore gliding. I'm not trying to restore anatomy. I'm restoring gliding. So I would typically put on one of these dynamic external fixators. You could put other ones on. This is a bit broadened. There's a bit of a gap there, but that has the ability to glide centered about that point of rotation. Here's a different injury. These are not mine radiographs. These are from Andy Logan in Cardiff. He kindly let me use them. And you can see here, he's put a plate on. Now, what many people might think is that he's restored anatomy. And I would argue that actually what he's done is he's restored gliding. And that's how I think this treatment works. Now, I personally wouldn't do this, but I know others who would, and I'm not here to talk about that. But I think to talk about the principle of restoration of gliding, because I think that's what matters with these. And if you can get them to glide just on their own, don't try and do anything else. So when I see these injuries, pilon fractures and fracture subluxations, I take lateral flexion x-rays, and if they glide, I mobilize them and don't need to, maybe 1 or 2 follow up. I think you could do that down the phone now. And if they pivot, then I want to make them glide. So in conclusion, thank you very much for listening late in the evening. As I've said, and many others have said before, most hand fractures do not need surgery. And I would argue even more so now. You need to ask yourself, can you reliably improve on the natural history of that injury? And sometimes we know that, and I've talked about some of the research that's been done, and sometimes we don't, like pilon fractures at MP joints, and we ought to know what the natural history is, because our patients deserve to know to be able to, for us to be able to advise them whether we should intervene. Non-operative patient is generally not nothing. Now, for the metacarpal necks in the young boxing males, it's generally going to be getting them going and discharging them. But for some of these other injuries, you need a little bit more care and follow-up. Although I think a lot of that can now be done by down the phone or in video. I would encourage you to know the literature. We can't know it all, and I certainly don't. And also just to think about subset analysis or biases. Are you being influenced by the odd case which is skewing your practice? And I'm going to leave you with 2 questions. The first is, and this is true really for all surgery that we offer, how many people need to be a bit better for the small percentage who are ruined when we operate? And I've had terrible disasters that I will take engraved on my heart to my grave, as I suspect many of you will. And most of those have not been non-operative. And then finally, where are all those patients who had bad hand fractures treated non-operatively over 30 years ago? Why aren't we seeing them in our clinics? Because we see the scapholunate ligament injuries and the scaphoid non-unions who've done badly 10 years down the line, but we don't see many of these other injuries. And I think that the hand is very forgiving. And I would argue that once they've got to about 2 years, they don't really deteriorate. I think it's not like the lower limb. And I think that the hand recovers much better than we've given it credit. So thank you very much indeed for listening. Stay very safe in the months ahead and do a bit less operating. Thank you.
Thank you very much for that, Gray. That was great. That was fantastic. What I'm going to do, I'm going to stop the recording. We've recorded this talk. We're planning to put it online. So if you watched online, thank you very much.